Welcome everyone to this lecture on trauma, focusing on key orthopedic topics. Today we will cover important aspects related to pelvis and acetabulum fractures, shock management, open fractures, compartment syndrome, osteomyelitis, and more. This presentation is designed to enhance your understanding and prepare you for FRCS trauma and orthopedics examination. Pelvis and acetabulum fractures require a detailed understanding of anatomical landmarks such as the teardrop and sorsal. The teardrop's lateral border forms the true acetabular floor, while the medial border aligns with the true pelvis. The sorsal, characterized by increased sclerosis, forms the weight-bearing area and is congruent with the femoral head. Mastery of these concepts is critical for accurate radiological assessment and management. The iliopectineal line corresponds to the anterior column of the acetabulum, and disruption indicates an anterior column fracture. Similarly, the ilioischial line represents the posterior column, with disruptions suggesting a posterior column fracture. Identifying these disruptions on imaging is crucial for diagnosing and planning treatment for acetabular fractures. Key angles in the hip include the lateral center edge angle, normal, 25 degrees to 40 degrees, dysplasia, less than 20 degrees, overcoverage, greater than 40 degrees, and the neck shaft angle, normal, 125 degrees to 140 degrees, coxa vara, less than 120 degrees, coxa vulgar, 125 degrees to 140 degrees, 140 degrees. Understanding these measurements aids in diagnosing conditions like dysplasia and deformities, guiding treatment decisions. Hemorrhagic shock is categorized into 4 classes based on blood loss, heart rate, blood pressure, urine output, pH, and mental state. Resuscitation strategies vary, with fluid replacement indicated for classes 1 and 2 and blood transfusion for classes 3 and 4. Maintaining a 1:1:1 ratio of RBCs, platelets, and plasma is essential for effective management. Effective resuscitation methods involve monitoring parameters like urine output, 0.5 to 1.0 milliliters per kilogram per hour, serum lactate levels, less than 2.5 millimoles per liter, and base deficit, -2 to +2. Septic shock and hypovolemic shock can be differentiated based on systemic vascular resistance. Septic shock is characterized by decreased systemic vascular resistance, while hypovolemic shock shows increased systemic vascular resistance. Recognizing these differences is crucial for diagnosis and targeted management. Early appropriate care parameters include lactate less than 4.0 millimoles per liter, pH greater than or equal to 7.25, and base excess greater than or equal to -5.5 millimoles per liter, guiding the optimal timing of surgery within 36 hours of injury. Open fractures require immediate attention, with antibiotics initiated within 1 hour as per BOST guidelines. Debridement timing depends on contamination levels, ranging from immediate for highly contaminated wounds to within 24 hours for low-energy open fractures. Following these protocols reduces infection risks and optimizes outcomes. The MESS evaluates the viability of traumatized limbs, considering factors like ischemia, age, shock, and injury mechanism. A score above 7 predicts a low likelihood of limb salvage. This scoring system guides decision-making in complex trauma cases. SERS is defined by criteria such as heart rate greater than 90 beats per minute, abnormal WBC counts, altered respiratory rates, and temperature deviations. A score of 2 or more indicates SERS, aiding in the early identification of systemic inflammatory states in trauma patients. Amputations are performed with the aim of preserving as much functional length as possible. Important considerations include selecting an optimal level to enhance prosthetic fitting, ensuring a stable soft tissue envelope, and maintaining balance through techniques such as adductor myodesis. The metabolic cost of walking increases with proximal amputations, but CIME amputation is an exception, being more energy efficient than midfoot amputations. Wrist disarticulation preserves the radial styloid flare. Transradial amputations allow easier prosthetic fitting, and elbow disarticulation prevents bony overgrowth in children, making it a preferred option over transhumeral amputations in pediatric cases. Transfemoral amputations aim to maintain as much limb length as possible for effective prosthetic fitting. The ideal cut is made 10 to 15 centimeters above the knee joint. A technique involving 5 to 10 degrees of adduction improves prosthetic function. Adductor myodesis is critical in these cases as it enhances clinical outcomes by creating dynamic muscle balance and providing a soft tissue envelope for better prosthetic fitting. Gritty-Stokes amputation, performed near the adductor tubercle, includes patellar arthrodesis to the femur, which improves end bearing and maintains prepatellar soft tissue. This approach yields superior outcomes compared to standard transfemoral amputation. Cyme amputation, also known as ankle disarticulation, is more energy efficient than midfoot amputations. It requires a patent tibialis posterior artery and a stable heel pad for optimal outcomes. The surgical technique involves removing the medial and lateral malleoli flush with the distal tibia's articular surface. 16th. Bone overgrowth is a common complication in pediatric patients, requiring careful long-term monitoring. The leg is divided into 4 compartments, each with distinct functions and musculature. The anterior compartment facilitates dorsiflexion of the foot and ankle, including muscles such as tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. This compartment is most commonly involved in compartment syndrome and is innervated by the deep peroneal nerve. The lateral compartment supports plantar flexion and eversion, comprising peroneus longus and peroneus brevis. The deep posterior compartment enables plantar flexion and inversion, involving tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Finally, the superficial posterior compartment focuses on plantar flexion, with muscles such as gastrocnemius, soleus, and plantaris. The physical exam for compartment syndrome includes the 6 P findings: pain with passive stretch, the most sensitive indicator, paresthesia and hypoesthesia, nerve ischemia, paralysis, a late finding, palpable swelling, and absent peripheral pulses, another late finding. Emergent fasciotomy is the definitive treatment for clinical presentations consistent with compartment syndrome or when delta P is less than 30 millimeters of mercury. It is important to note that intraoperative measurements of delta P may be influenced by anesthetic agents, and only observation is required if delta P is less than 30 millimeters of mercury in anesthetized patients. The foot is divided into 9 main compartments. The medial compartment includes the abductor hallucis and flexor hallucis brevis muscles. The lateral compartment comprises the abductor digiti minimi and flexor digiti minimi brevis. There are 4 interosseous compartments and 3 central compartments. The central compartments are further divided into superficial, housing the flexor digitorum brevis, central, quadratus plantae, and deep, adductor hallucis and the posterior tibial neurovascular bundle. Treatment for compartment syndrome of the foot involves emergent fasciotomies performed via dual dorsal incisions. Osteomyelitis can be caused by unusual organisms in specific patient populations. Salmonella is associated with sickle cell anemia, but it is important to note that Staphylococcus aureus remains the most common organism. Pseudomonas is common in IV drug users or shoe puncture wounds. Bartonella may occur in HIV/AIDS patients after cat scratches or bites. Fungal osteomyelitis is seen in immunosuppressed patients, and tuberculosis can present as Pott's disease. Laboratory analysis for osteomyelitis includes elevated WBC count in 1/3 of acute cases, elevated ESR in both acute and chronic cases, and C-reactive protein, CRP, which is the most sensitive test, elevated in 97% of cases. Blood cultures may be negative but are used for hematogenous osteomyelitis. Microbiological confirmation relies on bone biopsy and culture, as sinus tract cultures are not reliable. The NEAR classification categorizes distal clavicle fractures into 6 types based on location and stability. Type 1 fractures are stable, located lateral to the coricoclavicular ligaments, and minimally displaced. Type 2 fractures are unstable, subdivided into IAA, medial to the ligaments, and IBB, lateral or between the ligaments, with significant displacement. Type 3 fractures involve the articular surface and are stable, but may predispose to AC joint arthritis. Type 4 fractures occur in children, affecting the growth plate and are typically stable. Type 5 fractures are comminuted and unstable, while type 6 fractures are rare and involve inferior displacement. Management strategies depend on fracture type, with stable types treated non-operatively and unstable types often requiring surgical fixation. Scapular fractures are often associated with thoracic injuries, including hemothorax or pneumothorax, pulmonary contusion, and head injuries. Orthopedic complications include rib fractures, ipsilateral extremity injuries, and brachial plexus injuries. Surgical intervention is often required for severe cases involving neurovascular compromise or high instability. The Eidelberg classification describes glenoid fractures in 6 types. Type Y fractures involve the anterior rim, while type 2 fractures exit inferiorly through the glenoid fossa. Type 3 fractures exit superiorly, and type 4 fractures involve medial exits through the scapular body. Type V combines features of types 2 and 4 or 3 and 4, while type 6 represents severe comminution. Treatment is tailored based on fracture type and associated injuries. Scapulothoracic dissociation is defined as a traumatic disruption of the scapulothoracic articulation. It is diagnosed when the scapula is displaced more than 1 centimeter from the spinous process. Mechanisms include lateral traction injuries. Commonly associated injuries include scapular and clavicle fractures, as well as vascular and neurological injuries. Proximal humerus fractures are associated with axillary nerve injury. The Hertel criteria help assess humeral head viability, considering factors such as calcar length, medial hinge disruption, fracture complexity, displacement, and angulation. Treatment ranges from conservative management to hemiarthroplasty for complex cases. Hemiarthroplasty is indicated for complex proximal humerus fractures, especially in younger patients. Key technical tips include ensuring the proper height of the prosthesis, securing the greater and lesser tuberosities to the implant, and achieving optimal alignment using landmarks such as the pectoralis major insertion. A spiral fracture of the distal third of the humeral shaft, the Holstein-Lewis fracture, is often associated with radial nerve injury. Up to 22% of patients may experience neuropraxia. Surgical fixation is often required for stabilization. IM nailing of humeral shaft fractures carries risks to neurovascular structures. The radial nerve can be affected by lateral to medial distal locking screws, while anterior-posterior screws may endanger the musculocutaneous nerve. Proximal locking screws can risk injury to the axillary nerve. Tendon transfers can restore function in radial nerve palsy. The pronator teres is often transferred to the extensor carpi radialis brevis for wrist extension, and the palmaris longus can substitute for thumb extension. Meticulous planning is crucial for optimal outcomes. An example question: what is the strongest predictor of future fragility fractures in a 70-year-old female? The answer is previous fragility fracture. Another example question: in which of the following scenarios would damage control orthopedics be the most appropriate? The answer is initial lactate of 2 with current lactate of 4. Ready to conquer the FRCS and EBOT trauma and orthopedic exam? Look no further than Orthomcqhub.com, your exclusive destination for over 1,600 exam-based questions meticulously designed to ensure your success. All the essential questions you need are found exclusively on our website, providing you with a comprehensive and focused study experience. Join us today and embark on the correct path to mastering your exam with the Orthomcqhub Question Bank. Don't wait. Elevate your preparation and secure your future in orthopedics with Orthomcqhub now.